Hi there, this is Dr. Overgard. Welcome to the asynchronous lecture on healthcare economics. This is an overview of some key points about healthcare economics, what it is, what it isn't, and how it fits into population health. Our student learning outcomes are to define healthcare economics and differentiate it from other related concepts such as healthcare financing and reimbursement. We also want to be able to discuss the intersection of healthcare policy and healthcare economics, to evaluate healthcare economics as an influence on population health, and then to be able to apply that knowledge of healthcare economics to decrease health disparities and promote social justice. This slide and the next contain a glossary of some key terms related to this lecture and to the references at the end. Cost-benefit analysis, cost-effectiveness, cost minimization, and cost utility we will discuss more thoroughly in another slide. And we will delve into healthcare economics more thoroughly, as well as healthcare financing, healthcare reimbursement, and a few terms that are here we won't discuss quite as deeply. Healthcare economics, what is it? Well, broadly, healthcare economics is a term used to describe the various factors that influence the cost and spending, which in turn influences the health of populations. These factors include the role of individuals, healthcare providers, insurers, government agencies and organizations in healthcare costs, and other factors such as drug and device costs, research, stakeholders in the forms of communities, and perhaps most importantly, the role policy plays in healthcare decisions and outcomes. Health economics is also a field of study and provides us with tools to think about ethical and practical ways in which scarce resources are managed or allocated and used to promote value and optimal healthcare outcomes. It is also part of domain 3 of the AACN Essentials that require the contemporary nurse to be able to discuss and consider the socioeconomic impact of the delivery of healthcare, including the ability to really describe and access and equity implications, and to prioritize patient-focused, or in our case in population health, community action plans that are safe, effective, and efficient in the context of available resources. This competency is really an essential element of contemporary nursing practice because the societal transition from a world of certainty and perceived abundance for some people and this new paradigm we're living in of scarcity across almost all groups but the very richest, it really characterizes today's healthcare delivery, in which healthcare is expensive, it's fragmented, and it's characterized by irregular quality. Health economic principles also provide a lens to address global issues such as migration, displaced people, climate change, vaccine access, and really injuries, obesity, and even pandemics. Healthcare economics really encompasses how we finance our healthcare, how we decide what to pay for and for whom. It's really inextricably entangled with the quality of the healthcare we receive, and it's also entangled with other social problems like the ones I mentioned just above, climate change, vaccine access, pandemics. And I think hopefully by the end of this lecture, you'll see that it is directly related to healthcare policy. Yet until recently, really, nurses in the US and physicians and other providers, we were socialized to believe that it's unethical to even consider the cost of care when making treatment decisions. Earlier generations of healthcare personnel, including myself, were imprinted with this myth of endless abundance, and we believe that there should be no limits on what is done for patients. I can clearly recall sending patients home with extra of every type of supply that they might need as they were discharged without charging them anything. And those were days when we didn't have any charge tickets on any supplies we used. There was one price for the daily rate, and it made it really easy not to think much about the cost. I have a background in finance, so I understand the idea of a balance sheet, but quickly came to realize that in contemporary field of healthcare, resources within the acute care setting and in terms of public health care and population health are just not unlimited. Difficult choices about resource allocation will be and need to be made in every single setting of healthcare. And understanding some of the models, theories, economic terms, and ideas will help you to understand and apply them in the practice setting. Moreover, understanding the roles economics, policy, and the interplay between them will solidify the relationships between these two critical influences and healthcare equity. So, why is it important? Well, healthcare is a key part of the US economy, and healthcare economics really affect the quality of healthcare delivered. It impacts the quality of population health activities and healthcare promotion, and in turn, our burden from chronic disease. It can be used as a fundamental measure of healthcare equity, and it's a key driver in terms of nursing issues, both professionally and personally. So let's look at these one at a time. First of all, healthcare is big business, at least in the United States. In 2022, Medicare estimated that U.S. healthcare spending grew 4.1%, reaching $4.5 trillion, or about $14,000 per person. $4.5 trillion. I can't even wrap my head around that. As a share of the nation's gross domestic product, health spending accounted for 17.3% in 2022, and now the World Health Organization estimates that it's just over 21%. On this slide, there's a link to the WHO site, which provides up-to-date information on the business of healthcare, and you can explore this delving in deeper into the United States, but you could also explore this by all of the other countries shown here as well. It's pretty interesting, so maybe take some time to take a look. Healthcare economics also affects the quality of healthcare delivered. I think the US is an example of how money spent as a measure by itself doesn't really translate into better health. We just looked at US spending in relation to other countries, and it's high, but people in the US are dying more frequently of avoidable conditions than in other developed countries. As of 2020, people in the US died of avoidable conditions at 336 souls per 100,000 overall. Do you want some examples? Well, in the US, 4 out of every 1,000 live births resulted in infant death, which is the most of any other of the wealthy nations studied. But it's really in maternal mortality that we stand out. Nearly 24 in every 100,000 US mothers in labors don't make it out alive. That's well above the next highest nation on the chart, which is New Zealand, and they come in with just under 14 per 100,000. And if you are a Black or a brown woman having a baby, you are twice as likely to have a serious problem or die while giving birth than your white counterpart, and so is your baby. Black women alone almost 4 times more likely than other women in the US to encounter serious problems or death in childbirth, and so are their babies. So clearly, money alone is not enough to account for the burden of chronic disease or the type of care we give. Healthcare economics also impacts the quality of population health activities and healthcare promotion, and in turn, chronic disease burden. Disease prevention and health promotion share many goals, and there's considerable overlap between those two functions, prevention and promotion. But on a conceptual level, it's useful to characterize disease prevention services as those primarily concentrated within the healthcare sector, and health promotion services as those that depend on intersectorial actions, or you could say concerned with the social and structural determinants of health. Yet, despite evidence that health promotion and disease prevention can be effective, nearly 43% of Americans are considered obese, whereas the average rate in other countries, actually, I think the average rate in 13 of the wealthiest countries is just 25%. And obesity has been shown to carry a host of comorbid conditions. In terms of mental health, we also have the third highest suicide rate, which doubles that of the UK, the lowest of the bunch. And the US eclipsed other countries by more than 5 times the rate regarding deaths from assault. We had 7.4 4 deaths by assault per 100,000. Now, it's unclear about the statistic. What's really unclear about it is how the availability of guns plays into the equation, because it's very fluid and easy to obtain a gun in the United States, but I think it's still a shocking statistic all the same. Regardless, healthcare economics is really a fundamental measure of healthcare inequity. Remember that healthcare economics is more than just money spent. It's the value for the money spent and the return on the investment that we put into it. But we do know that the unequal distribution or burden of negative determinants of health is really costly to the system. In 2018, the estimated economic burden of racial and ethnic health inequities was $421 billion using MEPS. I'll talk about that a little bit more in a minute, or 451 billion using the behavioral risk factor surveillance system data. The BRFSS, or Behavioral Risk Factor Surveillance System, is information that's gathered by states as part of a state assessment that they use to obtain federal aid. And the MEPS is a medical expenditure panel survey, which again helps estimate the cost of various expenditures across different states. The estimated total burden of education-related health inequities, so this is differences in health education and how it translates to health, was $940 billion. So education access and quality, which we have learned is a universal determinant of health outcomes and health decision making, was directly tied together in this meta study, and the relationship was clear. We saw a similar correlation when we looked at infectious disease in an earlier lecture. Most of the economic burden was attributed to the poor health of the Black population. However, the burden attributed to American Indian, Alaskan Native, or Native Hawaiian and other Pacific Islander populations was disproportionately greater than their share of the population. Most of the education-related economic burden was incurred by adults with a high school diploma or general education development, that GED certificate that sometimes people earn when they don't graduate from high school. However, adults with less than a high school diploma accounted for a disproportionate share of the burden. Although they make up only 9% of the total population in the US, they bore 26% of the cost for health. That's really high. The economic burden of health inequities is unacceptably high. I think that you can say that it warrants investments in policies and interventions to promote health equity for racial and ethnic minorities. And again, these adults with less than a high school degree, and in turn, really adults with less than a 4-year college degree. And if we do that, we may drive down the cost of acute and chronic health care and preventable deaths, as well as open up more money to invest in health promotion. So if all that doesn't shake you up a little, then let's consider that health economics is a key driver in terms of nursing issues, both professionally and personally. Nursing is a cost in healthcare, and it's not a revenue at this time. Yet, the Agency for Healthcare Research and Quality concluded that there's substantial evidence that increased RN staffing versus other nursing assistive personnel, or LPNs, so RNs versus nursing assistants and LPNs, is associated with better patient outcomes. The lowest mortality was found in hospitals where nurses on average cared for 4 patients each, and 60% had at least a baccalaureate degree. The highest mortality was found in hospitals where nurses cared for an average of 8 patients each, but only 20% had baccalaureate degrees. Because nursing is considered a cost rather than a revenue in the hospital context, nursing is a constant target for cost reductions. And consider that institutions are not directly compensated for providing nursing care, although they are for physician services. So there's little motivation for providing the right amount of nursing to meet patient needs. Some people even argue that direct reimbursement for nursing in hospitals would have a positive impact on quality by better aligning the intensity of nursing care with hospital reimbursement levels and thereby reducing incentives to inappropriately ration nursing care. But both policy and industry directions and decisions about cost containment in healthcare have had important negative impacts on nurse workforce sufficiency and in turn quality and safety. And there continues to be a substantially stronger research literature documenting an association between investments in nursing and better patient outcomes. Many studies have also confirmed that the higher patient to nurse ratios are associated with an increased odds of nursing burnout. For example, a 2002 JAMA study found that for each additional patient per nurse, the odds of burnout are increased by 23%, and the odds of job satisfaction are increased by 15%, just adding one patient to your patient load above 4. A 2018 meta-analysis also found that higher nurse-to-patient ratios were associated with adverse nurse outcomes, including burnout, and in particular, intention to leave the profession. So in terms of you and I, our ability to deliver quality and safe care, to make a living, and to not burn out, health economics is really key. So let's briefly take a look at healthcare financing, or how we pay for healthcare. The process of generating, pooling, and allocating resources for the funding of health services is really what health financing is. It's a separate topic from healthcare finance. Healthcare finance refers to how society pays for the healthcare services it consumes, but this is how we gather the money for it. Payment sources come from a variety of ways, including government funding, taxation, out-of-pocket payments, including premiums. So all of those out-of-pocket payments that you make and your premiums are known as cost sharing. It can also come from private insurance, from donations, or voluntary aid. The effects of corporate and government healthcare financing policies on such groups such as patients, businesses, hospitals, and physician providers is really key. Now, we talked about how policy has legislated 3 major funding sources in the U.S., and those legislated programs include Medicare, Medicaid, and Social Security for people with disabilities. Because in this case, it's important to note that Medicare sets prices through a series of administrative calculations, including the RVS, or the Relative Value Unit Scale. And what they do is they try to calculate the estimated amount of work and practice expense involved in delivering specific services. The program also uses various payment schedules for different kinds of services. And basically, it uses the maximum amount the federal government will pay and plans for care for the average person in each county in the United States. So it varies by state and county. In 1989, they passed the OBRA, the Omnibus Budget Reconciliation Act, and that actually established performance standards to control expenditures on physician services. So hospitals and providers who have better outcomes get paid more than those who don't. States do have the option to charge premiums and to establish patient out-of-pocket costs, making it possible for Medicaid enrollees who have some means to share in those out-of-pocket costs, and that includes, like I said, co-payments, co-insurance, deductibles, and other similar charges. But maximum out-of-pocket costs are limited. States can impose higher charges for targeted groups for somewhat higher income people, but certain vulnerable groups such as children, pregnant women, they're exempt from the out-of-pocket costs in Medicaid. Access, or the Arizona Healthcare Cost Containment System, which is our Medicaid system, has a website that you can explore if you wish. And so you can click on the link to access that site. It's kind of interesting to see what they're paying for and what groups they cover. A RAND Corporation study in 2022 across all hospital inpatient and outpatient services, including both facility and related professional claims. They looked at employers, they looked at private insurers, what they paid, and on average, they charged and were paying 254% of what Medicare would have paid for the same services at the same facility. So they're charging some people more, and that makes them able to take care of Medicare and Medicaid patients. Access pays anywhere from 15 to 80% depending on the service, but providers who do take access often have other financial incentives offered to them, such as graduate medical school reimbursements or disproportionate share funding, where if a hospital or a provider takes on more Medicaid patients than is expected, they get a sum of money at the end. Some providers or hospitals either limit or do not routinely accept patients who have Medicaid or only Medicaid, really. And Mayo is actually one example of that. This slide is one that shows some of the quality data from 2 different hospitals. I like to show this as many people don't really understand that reimbursements for hospitals in many cases really depends on the quality. And I think you should know this as you think about where you're going to work or where you might seek care. Info on these 2 hospitals, Cottage Hospital in Santa Barbara, California, where I used to work, and Honor Health Thompson Peak, which is near here, is listed, and you can go in and explore various different types of information that they're publishing. These 2 hospitals, they make it really easy to find the information, but if you look around, you'll find some hospitals where it's quite difficult. One thing that's really easy to look at is transplant quality. It's a highly regulated area, and it's an area I used to work in, and all of the data is usually published on their website, but it can be very difficult to find in institutions that don't have the same quality as others. But again, this just underscores that quality is an important variable in healthcare economics. So how is population health funded? Well, it's funded in some of the same ways as healthcare is, by taxation. One mechanism is derived from the IRS community benefit requirement, which calls on not-for-profit hospitals to provide a benefit to their communities, commensurate with their tax exemption. So you'll often see that not-for-profit hospitals routinely do a CHIME study where they do a community health needs assessment so they can understand what areas would benefit their communities the most. There's also bad habit taxes, which are taxes on liquor or cigarettes. There's some mandated legislation. The Prevention and Public Health Fund was established in 2010 under the Affordable Care Act, and it's also known as the Prevention Fund, or PPHF. It really was the first mandatory funding stream in this country dedicated to improving the public health system. By law, the Prevention Fund must be used to provide for expanded and sustained national investment in prevention and public health programs to improve health and help restrain the rate of growth in private and public health care costs. Another mechanism involves redesigning the payment system and leveraging health system financing to increase the service breadth across health systems, as well as their connection with other players in the field. These are often called managed care strategies, and what they are is they're focused on keeping highly vulnerable patients out of the hospital by taking steps to address health needs in the community and often to address non-clinical needs that are linked with health outcomes such as food insecurity. One example of this is the food prescription program at Desert Mission, which is the charitable arm of Honor Health, or the community arm of Honor Health. and they provide fresh, healthy food, which is delivered right to providers' offices to patients identified by the provider as needing more access to healthy foods for whatever medical condition they have. But it's important to point out that most reimbursement methods that aim at reducing hospital admissions can be a disincentive for some systems to engage in population health because the payment system for those that are not in managed care does not reward health systems for these kinds of reductions. The reward or the profit comes from having people in the hospital, not keeping them out of the hospital. Non-governmental organizations, including one like the Bill and Melinda Gates Foundation, they also address a multitude of social efforts, including health, in various ways, as well as smaller, more focused foundations, such as the CF Foundation, who focus on the needs of one particular population. So those are those NGOs we've talked about before. Let's look at how population health programs are developed. You already have some experience in this area. You use the community as partner model, which is one type of model, to assess a community. In this case, or in your case, it was a community partner. You explored the stressors and the capital in your analysis, and you came up for a plan that had an intervention that was feasible for you to do in the time allotted. To decide what was feasible, you had to identify the resources available, you had to identify the constraints, and you may have and really should have considered alternatives. And we'll talk more about that as a function of healthcare economics in just a minute. But I want to point out one more step. Initially, in your assessment phase, you consulted your stakeholders about what they were looking for and what they needed. But after deciding on an intervention, you need to go back and check with your stakeholders if they're not already at the table. Because healthcare economics is about more than just the money. It's about the utility and the value and whether or not it's a good fit or good intervention for the population that you're trying to serve. It's the right intervention at the right price with the best outcomes. So an interesting example is a 2019 systematic review that looked at interventions aimed at behavioral treatment of weight loss using a wearable activity monitoring device similar to a Fitbit. And the idea was that if you gave people Fitbits, that they would exercise more because they would be motivated, and then that they would lose weight over time and keep that weight off. But when a study looked at that particular intervention, at 24 months, those who wore the monitor, some people weren't wearing the monitor, but those who wore the monitor had lost less weight than a control group. So they it didn't work over the long term. Now, various factors were cited for this particular example, but one was that activity is not the main driver for weight loss, especially among some of the younger groups in the interventions. They were active, but the problem wasn't activity, nutrition was the problem, particularly, like I said, for those younger groups. And in older groups, it was other health problems that kept them from activity. Let's look briefly at deciding what to pay for. As we just said, there are a lot of things we can put into place to try to improve the health of individuals and communities. Blood pressure medication, weight loss programs, screening programs such as cancer or screening or osteoporosis screening. And if we had enough money, we could put them all into place, but we don't. And if we spend too much on one intervention, then we don't have any left for the others. So one thing we need to think about is the opportunity cost. That's the limited amount of money that we have, and how do we get the most bang for our buck out of it? Now, there's several ways to compare interventions by cost. Cost minimization, cost effectiveness, cost utility, and cost benefit. So, for example, for cost minimization, what we can do is we can simply compare the cost of the same intervention. Our example here is comparing two drugs that do the same thing. This is actually a really common strategy for insurers who often have a formulary for which drugs that you can get. One drug they may have contracted to use over another, or they may say you have to use generic over the brand name. Cost effectiveness compares two interventions that have the same endpoint. For example, weight loss intervention versus medication for high blood pressure. From the recent example about wearables, you can see that this is very difficult to decide over time and without a lot of research because one size does not fit all. So some people may lose more or may have better luck treating their hypertension with a weight loss intervention, where others may need medication or do better with medication. Cost utility, that compares different interventions for different things. And this is somewhat common in population or public health. Should we treat this thing or should we treat that thing? Should we combat obesity or should we promote cancer screening? This type of calculation often uses the QALY that it often uses QALY. QALY is a quality of life in years. That's what it stands for. And it's basically a measure about the greater the preference for a particular health state, the greater the utility associated with it. So the basic idea is that it assumes 1 year of life lived in perfect health is considered one unit or one utility, but a year of life lived in a state less than perfect health would be worth less than one. So in order to determine the exact quality, you have to multiply the unit or the utility factor with a given state of health over the years. So I get 5 years of so-so health or 3 perfect, which is better. And it requires a value judgment that's going to vary depending on who's looking at it. Would I prefer 8 so-so years of living with chronic pain or 3 great years without any pain at all? And what is the cost of each outcome? This type of analysis, while frequently used, is sometimes considered unethical because, again, it really depends on how people are looking at things and what they're using in their quality judgment. And it's also been known to disenfranchise some groups of people and lead to health inequity. And finally, cost benefit compares all of the costs, direct, indirect, and intangible. Let's see, do I have anything on here yet? I think the next slide, let's look a little bit more at that. Direct costs are associated with the treatment itself, with the healthcare team, transportation, all of the things that you would basically have to pay a medical facility, a pharmacy, or anybody for. Indirect costs are those things associated with being sick. So missed wages and maybe losing your house, maybe not being able to drive, things like that. And then intangible costs are those emotional distress costs such as pain and suffering. We're not going to do much more with these, but just remember as you care for people in and out of the hospital that no matter what happens to someone, there are direct, indirect, and intangible costs associated with their disease state. So a quick summary of the past few slides. We know that healthcare economics is more than just monetary cost, and we need to understand that our evaluation criteria needs to include a lot more than just dollar signs. Our evaluation criteria has to have clear objectives and SMART goals. And I know a number of people asked that as you guys were creating goals for your community intervention. It's got to consider those multiple paradigms, cost, outcomes, response. And then it has to measure quality. The evaluation must actually have a way that actually measures quality, not just cost. And the baseline and current data in place is there that can help you measure progress. And then also you need to make sure that you have validated outcome measures with stakeholder input. So how do we create healthy populations? Well, we need to look more broadly at all of the factors that influence the cost and spending and the health outcomes. To do that, we need to address the health outcomes of all populations and consider including the distribution of such outcomes within the group. David Kindig explains that populations are often geographic populations, such as nations or communities, but they can also be other groups, such as employees or ethnic groups, disabled persons, prisoners, or really any group as you define them. While universal determinants of health create a significant burden in health disparities that are maybe racially, ethnic, education related, the economic and outcome burden will be reduced if investments are made to address structural contributions or contributors to known inequities, including racism and socioeconomic inequalities. So with that, we have to come right back to a slide that should look familiar. It's our opening slide from the public policy lecture. It's really only through addressing issues via public policy that aims to allocate resources for all members of society that we can create programs and policies that are most needed to address health inequities and really overall increase health among everyone and decrease costs. So as we look at public policy, we know that it has to apply to all members of a given society, and that it's really the only way that we can go back through and make sure that health economics, all of these pieces of health economics are included as we make public policy. So that is a brief overview of something that could really be a whole course. I hope it was helpful in some ways. Please let me know if you have any questions. And there are some resources related to this lecture. Thank you very much. Have a great day.